ASH 2015 coverage continues. I'm Thomas Baldrick, joined again by Dr. Courtney DiNardo from the MD Anderson Cancer Center. Thank you. We appreciate your time.
Happy to be here. Thanks for the opportunity.
Okay, so you've been busy. Let's talk about IDH1 Mutation-Positive Hematologic Malignancies receiving AG120. What can you tell us about this as an overview?
Right. So acute myeloid leukemia, we've talked a little bit about this already, is a very kind of clonally diverse, heterogeneous patient population. The leukemia itself is very heterogeneous, and in about 20% of the time in acute myeloid leukemia patients, you'll have an IDH mutation, either an IDH1 or an IDH2. And similar to the FLT3 inhibitors that have become a well-known kind of targeted therapy in the leukemia world, we now have IDH inhibitors, IDH1 and IDH2 inhibitors that are now in the clinic. And so I presented the results, the preliminary results of AG120, which is the first-in-class IDH1 inhibitor for patients with relapsed or refractory or otherwise IDH1 mutant-positive leukemias. And so far we've treated 78 patients. And of those patients, we've seen some very nice responses in the relapsed refractory setting, monotherapy. So this is a difficult population to treat. Most patients have already had cytarabine-based chemotherapy, hypomethylating agent-based therapy, and there's not standard of care options available. And with a very well-tolerated oral daily pill, we've had about a 35% overall response rate. What's interesting about these responses is only about half of them are true CRs. We're seeing a lot of partial remissions. We're seeing quite a few stable disease patients that are deriving benefit. And so what's interesting about this compound and the other IDH inhibitors is we're seeing responses that go beyond the IWG official leukemia criteria. So we'll have patients that have a very nice improvement in counts. They're feeling great. They're no longer transfusion dependent. They're not getting infections anymore, but they still have documented leukemia. And so it's a little bit of a different kind of way to wrap your mind around these patients that are deriving clinical benefit but aren't necessarily obtaining the milestone of that CR that you really want them to. So it's definitely an interesting new class of therapy.
What does this mix of responses indicate to you?
I think what we have right now is a very effective drug for one specific mutation, and we know from the decades of work we've been doing that leukemia is not it's not just one mutation or one genetic change that leads to the leukemia, right? So there are many different things going on, and so my hope is that when we can move this forward into the frontline setting and come with other effective strategies, cytarabine-based, hypomethylating agent-based, that we'll see more kind of durable and more lasting responses. Yeah.
Of the results from your poster, what's most intriguing or most important to you?
I think what I was saying. So when you look at the patients that are responding well in study, we have patients, and it's early. The patients we've been enrolling since I want to say April of 2014 up until October of 2015 is this data cut. And in patients who are responding, we have patients on study for about 6 months is the median time on study. So these are durable responses, but you don't have to be in a complete remission to be doing well on study 6 months into therapy, which is a bit of a game-changing concept, I think, for us. So that's been the most notable. The other thing that's interesting about these compounds is they seem to promote a differentiation type effect. So similar to, in our world, the all-trans retinoic acid, the ATRA-related differentiation that we see in acute promyelocytic leukemia, that seems to be happening with the IDH inhibitors, where they are not cytotoxic, they're not killing the leukemia blasts, but they're actually allowing them to differentiate into their normal myeloid counterparts. So you still see the IDH mutation in these mature neutrophils. So it's an actual differentiation type effect. So that's been very interesting.
So where do you go from here?
So as I said, I think it's a bit naive to assume that a single targeted therapy is going to work in a multiply relapsed refractory setting on its own. So the goal is to move it up front in effective combinations for I think the best responses.
Thank you. We wish you luck.
Take care.